This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're here. Well, Thomas, I hate to say here we go again, but this new variant has reared its ugly head here in the United States.
Okay, if you don't want to say it, then I will. Ladies and gentlemen, here we go again. I remember Ronald Reagan. Well, there you go again. Here we go again.
Right.
Yeah, it's been, of course, in the news since Thanksgiving. So what are you hearing about it?
You know, what I'm hearing about it is really limited. I think we're going to have to wait another 10 days or so to really get the scientific evidence related to it. Anecdotally, the physicians, especially in South Africa, it's contagious, potentially more contagious than Delta. 2, it makes you ill, obviously, but not as ill as you might think. It's not worse than the Delta as far as severity. And then the third thing, of the people that are vaccinated, they don't tend to get as severe a case as unvaccinated. That's what we're hearing.
So it kind of seems like what you're describing is paralleling what we're already experiencing, what we've already been familiar with. So why do you think the reaction around the world was as swift and severe as it was?
You know, I'd only speculate, but here's what I think, Thomas. I think a lot of people thought back to Delta. If you think to late spring, early June, not a lot of people knew about Delta in the United States. Yes, it had been in Europe, then it spread quickly throughout the United States, and Delta became the predominant reason we had yet another surge. And I think that's what people thought about, and that's why we got the reactions we got.
Well, I remember that clearly. You know, my brother and sister-in-law were in St. Louis when all of that Delta was emerging, and yet we didn't know about it, and they both got it at a 4th of July get-together. Remember that clearly.
You know, and then it has the domino effect. You not only have people reacting to it from strictly a public health point of view, but you saw what happened to the stock market. I think some of the investors got scared. They thought, oh my goodness, we're going to have shutdowns, we're going to have business interruptions, and that's why the market dropped the way it did.
Yeah, it certainly seems like we are highly reactive to news about COVID one way or the other. But as you look in your own crystal ball, do you see a world without COVID, or is this a world that we have to coexist?
Yeah, that's a great question. And as you know, I'm not a medical doctor, and I'm certainly not a person that works with infectious disease, but I do enjoy talking to the professionals. Most that I talk to, Thomas, think it's going to be here for quite a while. COVID-19 potentially could be almost like the flu, where we have to get booster shots. And I'm not saying every year, maybe it's every other year, but, you know, we get flu shots every year. And flu changes. You know, they change what they put in the flu vaccine every year, hoping to guess they hit the strand that this flu shot will do the best against. You know, it could be that we're going to have to live with COVID and learn to coexist with it.
Well, in light of that, what does living with COVID look like in North Texas right now, at least from the hospital's perspectives?
You know, right now we've kind of leveled off. Nothing like where we were in the surge of the summer and fall. But I got to tell you, we still are running about 750 hospitalized patients every day in Trauma Service Area E. Now, I realize that's only about 6% of our capacity, but still, that's quite a few people with COVID, and we've got that. And now we're watching to see what's the impact of all the movement that occurred over Thanksgiving, and will any spread occur as a result of that? So we're watching it. It's leveled off. The last thing we need now is a new variant.
You know, we talked about last week or the week before long COVID, right? The effects of COVID after you've gotten well. I was talking to somebody just last weekend, over the holiday weekend, whose 65-year-old dad got COVID and is still, and he's what now, 3 months post, still having trouble breathing, can barely walk to the mailbox. This was a very healthy individual with no comorbid medical conditions who is experiencing the very effects that we've talked about with long COVID.
You know, you're right, Thomas. I talked to an individual and I said, hey, I hope you had a great Thanksgiving. And they said, yeah, I have a lot to be thankful for. But for the first time ever, I really didn't enjoy Thanksgiving dinner. And I said, why? And said, well, I got COVID 12 months ago prior to the vaccines, and my taste and smell has still not returned.
Wow, that's incredible. You know, another thing, and I know we've covered this extensively on our show, but when you reach out and hear these things in real life, and you know these things are going on with us, so people are still getting sick. We've got 700 plus in the hospitals. People are still having the long COVID effect. And then a nurse who I know who works in one of our local hospitals and works with COVID patients was saying exactly what we've talked about. In fact, she was encouraging somebody who she knows in her family to get vaccinated and was saying, look, the people who are in the hospital who are the sickest and the people who are dying are the people who are not vaccinated. The people who are vaccinated have less symptoms or less severe symptoms, even though they still have to be hospitalized to shore up that breathing. So it's nothing new here, but when you know somebody who is saying this, who works 12-hour shifts, seeing it firsthand, that's where we are. I mean, that's what living with COVID looks like.
You're exactly right. And when I talk to the physicians in all our hospitals, they say similar things. The majority of the patients are unvaccinated. The ones that are vaccinated that do have to get hospitalized have much milder cases. You know, Thomas, we've learned some things from COVID. Even with this new variant, let's wash our hands, use hand sanitizer, physical distance, wear a mask, do our research if we're not vaccinated to see if we can convince ourselves that we should get vaccinated. And even a new wrinkle, if you're currently vaccinated and haven't gotten your booster, maybe you should do so.
So let's just summarize here. From your opinion, this is a real deal?
I think it's a real deal because the World Health Organization says it's a variant of concern, but it doesn't mean we have to panic. And it does mean if we take the precautions, we hopefully are going to be okay.
And it's a little bit too early to form opinions.
Absolutely. Let's wait till we get all the facts. Once we have that, then we can come up with the next steps.
But it is enough of a threat or a serious enough reminder to go back to the basics. The mask, the distancing, the washing the hands, the vaccine, the things that we've been talking about for the last 2 years.
Absolutely. Not only for this new variant, it's going to help during flu season as well.
You know, Steve, what it seems like is we know what the tools in the toolbox are. Now we have to use them. And I hope, folks, that you choose to do that. Steve, thanks, and I know you'll be on DFW Media as this story unfolds and here next week. Now, if you take your fingers and run them down your neck on either side of your ears, we're going to talk about that area next, and what can happen there can kill you. Find out what about it next on the human side of healthcare.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back. We're going to talk about something we love to talk about, new medical procedures. And we're going to talk about a procedure today that helps prevent strokes, which are the number 3 killer in the United States. We're delighted we're going to have with us Dr. Yinn, who serves as a neurosurgeon at Texas Health Harris Methodist Hospital in Fort Worth. Dr. Wee, welcome to the show.
Oh, yeah, thank you. And thank you for the opportunity to be on the show and to be able to talk to your audience. Really appreciate the opportunity.
Dr. Wee, to help us set the stage, can you tell our listeners about strokes in general?
Yeah, so it's important for us to first start off by saying that strokes is the number 3 killer in Texas. Just in 2017, up to 10,000 Texans, unfortunately, have passed away from strokes. Every 40 seconds in the United States, someone suffers from stroke. every 4 minutes, someone dies from a stroke. So it's a very, it's a disease that has a significant impact on our community and this country as a whole.
One of the reasons we're talking today is about this new procedure. It's called TCAR. Can you tell our listeners what is it and what are the benefits from TCAR?
So what TCAR is it stands for transcarotid artery revascularization. And doctors just love fancy names because it makes it sound smart. But what TCAR is a minimally invasive surgery specifically designed to treat carotid artery disease in order to help prevent strokes. Not all carotid disease needs to be treated. We typically treat carotid artery disease when there is enough plaque buildup, enough calcium and cholesterol deposits within the artery itself, where there's a compromise of flow into the brain, or there's significant risk of some of that debris flying into the brain causing strokes. That's our cue as physicians that's a carotid disease that needs to be treated to prevent future debilitating strokes. And that's where TCAR would come into play.
So if I understand this correctly, it's kind of like the third generation in treating the disease. It's kind of a hybrid approach. Would you agree with that?
Right. So it's funny that you brought up the word third generation. So I think, to better understand what a TCAR is, we have to understand the context in which the TCAR was designed as a procedure. So carotid artery disease, traditionally, once you have failed medical management, meaning things like blood thinners and cholesterol medicines, traditionally has been treated using open surgery. Where neurosurgeons like myself would have to make a long incision along the neck, expose the carotid artery, open up the artery, clean up the artery by gently scraping off the debris and plaque buildup, and delicately sewing the artery back up. And while this is a very delicate surgery from a neurosurgeon standpoint, you can imagine how morbid that is for a patient, having this long scar along the neck, which is very much visible. And a procedure like that takes hours to perform, requires a few days stay, typically 3 days stay in the hospital. And there can be significant discomfort after a major surgery like this. So that would be what we call the first generation of a carotid artery treatment. And like most things in medicine, there is a trend towards shifting towards a more minimally invasive approach, or an endovascular approach, where we treat diseases of the vessels from within the blood vessel itself. So then came along the second generation of the carotid disease treatment, known as carotid angioplasty stenting. Again, doctors love fancy words, but in this procedure, an endovascular surgeon like myself would access an artery from the patient's thigh or wrist, and from within the artery, we push a long catheter all the way up to the neck. We inflate a balloon to open up the narrowing, and we keep the artery open with a stent. Now, with this procedure, you're only left with a very small stab incision along the wrist or thigh, and that takes about an hour and a half to complete, and patients get to leave by the next day. So that's the second generation of treatment. So one may ask at this point, so if that is a minimally invasive procedure that we can do for these patients, why is it not the current standard of care for patients with carotid disease? The interesting thing is, when that procedure, a carotid angioplasty stenting, was introduced, it was very, very well received at the time with a lot of enthusiasm, and it was actually hailed as the holy grail for carotid disease treatment. But one can easily imagine the challenges of treating a problem in the neck all the way from the thigh or someone's wrist. It's a long way up. And with that comes, its own set of challenges, and comes a much higher risk of complications associated with it. It can be difficult to navigate a catheter that long distance. And in doing so, we can inadvertently knock a little plaque that, if it flows downstream into the brain, can cause a stroke. So the irony about this second generation procedure is that while the procedure was designed to prevent strokes, there's actually a higher risk of causing strokes during the procedure itself.
Thanks for explaining the first and second generation. Naz, this where TCAR comes into play?
Right. And that's a great question, because that is why most of us who do TCARs consider TCAR as the quote-unquote third generation of carotid disease treatment. And this is why it's crucial to make sure that when you have carotid disease, you're evaluated by a physician who's dual trained in both open surgery and endovascular techniques. Because TCAR is really a hybrid procedure. It capitalizes on the advantage of the direct access provided by open surgery and couples that with the minimally invasive nature of treating carotid artery disease with a balloon and a stent. So in this procedure, to answer your original question of how is this procedure performed, instead of a long 5 inches long incision across the neck, we make a 3/4 inch incision just above the collarbone, which can be easily hidden by one's t-shirt. And that allows us to expose the carotid artery right at the neck. We stick the carotid artery directly, and we perform the balloon and stenting right there at the neck. And that gives us very precise control of what we're doing, and has really led to significant improvement in patient outcomes. TCAR has the lowest complication rate of any carotid disease treatment so far. And I think it's if I may point out one of the unique things, and this may be a concept that may be a little bit more challenging to understand, but during the procedure, we gain access to the patient's vein in the thigh as well. And the vein is what drains blood away from the body, as opposed to the artery, which is what we're treating, that brings blood to the body. And since veins have much lower pressure compared to arteries, this allows us to temporarily reverse the flow from the neck to the leg. And if any debris gets knocked up while we try to open up the artery, instead of the debris flowing down into the brain causing strokes, it gets flushed to the leg and it gets captured by a filter, preventing strokes from happening during the procedure. And that is why TCAR has the safest track record so far.
I'd like to ask what the red flags are. Gender, age, what are the hot spots as far as getting carotid disease?
Carotid disease typically affects the older patient population. It also typically affects people with multiple medical conditions, such as high blood pressure, diabetes, high cholesterol, obesity, patients that typically don't tolerate major surgeries very well. One can imagine as we grow older, since the disease involves the deposition and collection of cholesterol, calcium, and plaque, that just worsens with time. There hasn't really been any association with any specific gender or race specifically, but it's definitely been associated with less than healthy lifestyle, if we can put it that way. So high cholesterol diet, eating lots of red meat, and not engaging in routine daily exercise.
Dr. Wee, that's such a great point. And what about prevention? I mean, prevention is key to all of these diseases, including this one, correct?
Well, 100%. I think you really nailed it there by saying that the best treatment for carotid disease is prevention. Now, unfortunately, there are some folks that are more likely to develop carotid disease than others. It's in their genes, so to speak. But apart from that, it's really doing the things that we've been normally encouraged to do. It's eating a healthy diet, avoiding high saturated fat diet, exercising regularly. And I think one of the important advice that I can give to your listeners is really to follow up routinely with your primary care physician to make sure that your blood pressure is well controlled, your cholesterol levels are where they should be, and your sugar levels are well controlled as well. I think, very routinely when I see patients with carotid disease, the overarching pattern is that, well, I haven't really seen my doctor for a while now. I'm overall healthy, but when we end up checking their labs, their numbers are not where they should be, and that has basically increased their risk of developing carotid disease.
We're listening to Dr. Cher Wee. He's a neurosurgeon at Texas Health Harris Methodist Hospital in Fort Worth. I knew a guy who was in his late 60s, came into the doctor's office feeling fine otherwise. The next day, he was on the operating table getting his carotid arteries operated on because they found blockage, and they prevented a stroke for that guy. As you heard, the number 3 killer in America, and certainly prominent in North Texas. More with Dr. Cher Wee from Harris Methodist Hospital in Fort Worth next on the Human Side of Healthcare.
Welcome back to the Human Side of Healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. We're continuing to talk about something that can save lives. This is such a big deal, and we're talking about cutting-edge new medical technology. The carotid arteries, either side of your neck, can get clogged and lead to stroke. We're talking with Dr. Yinn Cher from Texas Health Harris Methodist Hospital in Fort Worth. Dr. Last segment we talked about the TCAR procedure, the new procedure that's out. What about other things that you're anticipating on the horizon?
So, I mean, in the medical community, we're constantly trying to improve the safety, efficacy of the care we provide, and also the way in which it is delivered. TCAR is the latest generation of treatment for carotid disease in the neck, and I would say it is still in its infancy. We have not fully realized the potential of TCAR as a treatment modality just quite yet. However, we are also trying to push the technique and the technology even further. We're trying to explore its impact on blood vessel disease within the brain itself. There's certainly more to come. I am limited by what I can disclose since I'm involved in some of the early research process with the technique, but definitely stay tuned.
When we're talking about carotid artery disease, many, many years ago, was that also known as hardening of the arteries?
Yes, that would be, carotid disease is very colloquially known as hardening of the artery because as plaque, as cholesterol and calcium deposits itself in the wall of the artery, it does cause hardening of the vessel itself. So traditionally, that was what doctors would tell their patients. Now, as patients are becoming more and more well-informed of their healthcare, we like to avoid using that word and actually educating our patients on the right name of the disease, which is carotid artery disease.
Great. And I appreciate you clarifying that for any of our listeners that were doing the connection similar to me. You've been great. You've answered all these questions, but I'm going to ask you a difficult question. What should I have asked you I didn't? And what message do you really want to relay to our listeners?
I think, the whole motivation to do, this interview, honestly, is to really try to create awareness of how debilitating strokes can be and the significant impact it has on our community as a whole, and carotid artery disease being one of the major causes for stroke. I think it's important for our community to recognize that carotid artery disease is not a trivial disease to have. It can cause strokes, which leads to significant disability and death. And as a physician who treats stroke on a daily basis, I see how the lives of our patients and their families are impacted by this disease. And so I really want to just take this opportunity to create that awareness and to say, if you know someone who has already developed carotid artery disease, it is important to let them know that there are very safe and effective treatment procedures for the disease, and that not all of these procedures are created equal. And that's why it's really important for you to visit the right doctor, preferably someone who's dual trained to do the open surgeries and the minimally invasive endovascular techniques, who can perform all three generations of procedures that we just discussed earlier, so that person can tailor your treatment based on your needs. You need to talk to your doctor to discuss the different treatment options, especially to see if you're a good candidate for a TCAR, which, as we've mentioned, has the safest track record so far. For carotid disease, it is important to seek treatment at a high volume, high reliability center, such as at Texas Health. So if you have a carotid disease, we're more than happy to help in any way we can.
Thank you so much for this wealth of information. And it's really good to know that the TCAR procedure really is potentially one of the safest you can do. I'm going to pause because Thomas always has excellent questions.
Well, Dr. I've got one that's real life, boots on the ground. Yesterday I found out that a very close friend of mine died suddenly, and they're looking into whether it would be a heart attack or a stroke. And it begs the question, it could be either, right? We don't know at this point, so we can't go there. But can you have plaque buildup in either your heart or your carotid arteries, but not in the other area?
Right. And Thank you so much for sharing that story. And, I can only imagine how you're feeling right now. But that, the story that you just shared, unfortunately, is the kinds of story that we hear every day here treating stroke. When we share statistics, numbers only go so far, but it's really these personal stories that hit it close to home. But to answer your question, the answer is yes. It's both heart disease, in terms of coronary artery disease, meaning disease of the vessels of the heart, are caused by the same problems, the same factors that lead to carotid artery disease. Now, it is not uncommon that when we have patients with carotid artery disease, that they have vessel disease involving the vessels of their legs, their arms, their heart, their neck, and even the vessels of the brain itself. But we do occasionally see, and not really, it is not uncommon for us to see patients with isolated carotid artery disease or isolated coronary artery disease. But if those patients were to maintain the same lifestyle, maintain down the same track that they have been, those are very likely to eventually develop disease in their other blood vessels of the body.
So this guy was 53. Begs the question, how often should we get our carotid arteries checked?
So right now, there's no national guidelines to have your carotid arteries screened routinely. Certainly, anyone who has had any sort of symptoms that are akin to a heart attack, a mini heart attack, would automatically need their carotid arteries checked. That is part of our protocol within the healthcare system. But for a normal, healthy person, we still do not recommend screening carotid arteries routinely unless you develop symptoms. And the symptoms can be any symptoms that are akin to stroke. So numbness, tingling, weakness on one side of the body, even if they last for a couple seconds. Those are important things to discuss with your doctor. And if you have those things, that it's important to get screened for carotid artery disease.
In how many cases, I don't know if this is the best way to put this question. I'm just looking for a very broad answer, like majority or minority would be great. Does the body give you precursor or advance signals that a stroke might be on the way?
So the unfortunate answer to that question is actually the vast majority of people find out on the back end of things. So as an endovascular neurosurgeon, one of the things that I do is treat acute stroke when someone has an artery in their brain or neck that has shut down abruptly and are now actually in the midst of developing a stroke. If those patients come to us on time, when patient family and patients themselves are able to identify the system, get help immediately, call 911, get to the hospital immediately, we're able to go up there and retrieve and open up the artery, retrieve these clots, and patients do get better. But to answer your question specifically, unfortunately, more often than not, people find out on the back end of things where they've already developed symptoms.
Wow, well, you are doing the Lord's work, and thank you for sharing it with us. We really appreciate it. And when you can be less invasive, more effective, that's a win-win for everybody.
Yep. And it is a blessing to be able to do what I do. So thank you for your time. I really appreciate it.
Dr. Yinn Cher, he's a surgeon at Texas Health Harris Methodist Hospital in Fort Worth. And ironically, we're going to stay right there because next we're going to talk to a colleague who works in the emergency room at Texas Health Harris Methodist Hospital. This is Dr. Cesar Augusto Diaz, and he has an amazing story of how his family immigrated from South America, and that actually led to him becoming a physician. Dr. Diaz, we are interested in hearing your story. Welcome to the Human Side of Healthcare.
Oh, hello, Stephen and Thomas. Thank you so much for having me here. I'm glad to be able to speak to you folks about this important topic.
Let's go back a little bit in the past, if you would. Who exactly is Cesar Augusto Diaz, and can you tell us what you did prior to becoming a physician?
Well, as far as who I am as a person, everybody has a different story, but mine has definitely been shaped by where I come from. And I'm actually from South America, from Lima, Peru. and my family immigrated to Toronto, Canada, where I lived for 6 years. And then we moved here to Fort Worth, Texas. And so definitely shaped by all the places that I've lived, all the people that I've met from many different cultures. And before I was a physician, I was in college, pre-medical student who loved biology and science.
That's terrific. As you studied biology and science, what really motivated you and attracted you to become an emergency medicine physician?
Well, for me, it was definitely different experiences. I wanted to be a biologist, an actual biologist that worked with insects, entomologist. And unfortunately, my father ended up getting sick with cancer when I was in high school. And that kind of opened up my eyes to a world that I wasn't really aware of. Luckily, in college, I got to work as a physician record assistant, as a scribe, at the hospital that I'm working at right now, which is a coincidence, at Texas Health Fort Worth. And working alongside the emergency room doctors definitely played a significant role in choosing that specialty.
This is Dr. Cesar Augusto Diaz. He's an emergency room physician at Texas Health Harris Methodist Hospital in Fort Worth, telling us his story about how he got into medicine. It's such a wide open field, and we've been hearing a lot of the stories of what's going on in healthcare right now. So if you are looking for a career or maybe a career change, we're going to hear a very motivating story of a family that came to America and how Cesar Diaz became Dr. Diaz.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back to the human side of healthcare. We're going right back to our interview with Dr. Cesar Augusto Diaz, emergency medicine physician at Texas Health Harris Methodist Hospital in Fort Worth, talking about his career in medicine. Steve?
Dr. Diaz, you told us your story about coming from South America, living in Canada, your passion for science. Recently, the American Medical College Association said 6% of physicians in America are Hispanic. What are your thoughts on diversity in the healthcare workforce?
Well, considering how large the Hispanic population is in the United States, and that it continues to grow, it was kind of sad to look at the numbers. And I know we can do better. In the medical field, as a country, in our culture, we can do much better. And one of the things I believe would help is to start early. Start as parents with our children, motivating them, encouraging a listening environment, creating a welcoming environment. And then as that progresses later on, even mentoring programs at hospitals or with other doctors, just starting early and just encouraging young people to see that there are many doors that are open, especially in the medical field.
So if you were speaking to a room full of freshman college students, totally undecided on what their career would be, would there be 2 or 3 top reasons you would tell them to enter the medical field?
I believe, if you're a young person, what I would tell you would be, if you're interested in helping people, making a difference, and are very interested in science and medicine, technology, then medicine might be a calling for you. I definitely don't think it's just a straight up career choice. I definitely think it's a calling, but that's what I would say.
Being an emergency room physician, you have to be prepared to see almost anything. People come in maybe just for primary care, or people may be coming in with life-threatening things such as a heart attack or stroke. What, from your personal point of view, keeps you grounded?
Personally, for me, it is a difficult specialty, like you were mentioning. You can get anything from a minor ankle sprain or cold to somebody that's dying. And for me, that's something that's kept me grounded my entire career is my faith and my family. Having a strong, grounded relationship with my family members just keeps me afloat. And together, that and faith, they're my rock. I always try to stay positive, see the big picture, but that's what helps me.
Many times we read about health grades or grading a physician or grading the provider and what makes a good provider. Can you tell me not only what makes a good provider, but what makes a good patient?
There are various facets to this, and it's not a straight up question. There are many things you have to take into account, but I will say this, without going too much into it, but having that customer's always right kind of mentality that's kind of pervading our medical field is definitely not the way to go. Definitely, as far as patients, a good quality, I would say, is, trust in your physician, commitment to recommendations, having reasonable expectations, being patient, and participating in your care, and very important. And as far as for physicians, of course, always being empathetic, compassionate, understanding, being a good listener is a big one, having good communication skills, and always advocating for your patient. If they need physical therapy, if they need a referral to a specialist, it's very important that you advocate for your patient.
As we look to healthcare today, we look at healthcare professionals, and then we look 2 and 3 years out. As you know, in many specialties and in many allied health professionals, we need more people to enter this profession as a career. We know we've been dealing with COVID-19, so a lot of people have left the profession. What do you think are some things young people should really consider, in addition to some you've already covered, as to why they shouldn't be deterred about the pandemic and they should enter healthcare and make it a career?
I totally agree, Mitt. We definitely need to encourage more younger people to go into the medical field because we have such a shortage, especially with primary care physicians, especially in rural areas where people don't have access to medical care and to physicians. And for me, this is a hard time. The pandemic has definitely affected people, but I would tell young people, hey, the pandemic is a small blip in history. It will pass. Now, we will not forget, of course. We will always remember, but it will pass and better times will come. Just recalling the last pandemic in 1918 with influenza, where at least 50 million people died, and as a country, as the world, we persevered, we moved forward, and that's what's going to happen here. Things will pass, things will get better, and there'll always be a need for physicians. There'll always be a need to take care of people. And like the quote says, nothing lasts forever.
It's great advice, and I do agree with you. It's such a calling. Thomas always has excellent questions.
Thank you, Steve. I'm always interested in when people immigrate. They change countries, change cultures. How old again were you when you left Peru?
And so my family moved from Peru to Canada when I had just turned 9. And basically, we just started over. My dad actually worked for Pfizer, a North American company, but things were not going well in the country. A lot of instability, and we immigrated, started from zero.
Wow. And then you set your sights on becoming a physician. Now, tell us about how did you go from having, like you say, nothing to, I'm going to be a doctor one day. Was that piece tied to the immigration part, or is this something you probably would have done anywhere in the world?
I believe the latter. I've always been interested in science, biology, chemistry, physics since I was a little boy. My grandfather was an organic chemistry professor in Peru. And so, I've always been interested in science. And for me, it was just a natural leap into medicine. And I never thought, being an immigrant, it would be difficult because I already knew it was going to be. For me, it was just, I have a goal and I'm determined and I'm going to accomplish it.
We're talking about the theme of this conversation is pursuing a career in medicine. Obviously, that doesn't always have to involve medical school and that physician path, but give the young people in the audience a little peek behind the curtain of what medical school is like.
That is a very interesting question. I remember even as a pre-medical student hearing this, being pre-med is hard, but doable. There's a lot that you have to learn, but in medical school, it's a lot harder because everything is just so condensed and there's so much information. And I remember this quote to this day, because even the new medical students hear this quote, it's like trying to drink water from a fire hydrant. There's just so much information that you have to memorize and learn, but it's doable. It's been done before. It will be done after one goes through medical school. And it's just hard work and studying.
So let's say that you go into medical school and you get out, you go to work in an emergency room. What is that job like?
It's a tough job. It's not easy. There are some shifts that are easier than others. Positives for my work field, I get to see everything when they first come in. It's kind of undifferentiated. I feel I get to do workups and meet different people. And I do my shift and then I go home, and that's the positive. Thankfully, in my specialty, I'm not on call. I really don't have to answer the phone. I don't have regular office hours. And so that gives me a little bit more liberty as far as like personal time with my family and for myself. It's definitely not for everybody. There's some people that are meant for other specialties. And thankfully, this one fit me right.
If you ever wanted a peek behind the curtain to know what it's kind of like being a doctor, you just heard a great one. Dr. Cesar Diaz, emergency physician at Texas Health Harris Methodist Hospital in Fort Worth. Thank you very much for listening. Have a safe week. We'll see you next week on the Human Side of Healthcare.